I would like to welcome the very accomplished panelists we have with here today. We have Professor Gagandeep Kang, Executive Director, THSTI, Faridabad, who is also a member of the India Alliance Strategic Advisory Council. We have Professor Ajit Lalvani, who chairs the Infectious Diseases Division of Imperial College London, and who also chairs the India Alliance CPH Selection Committee. We have Professor K.M. Venkat Narayan from Emory School of Public Health, who is also a distinguished member of the CPH Selection Committee. We have Professor Nikhil Tandon, who heads the Endocrinology Department at AIIMS, New Delhi. He's also served on the India Alliance committees in the past. We have Professor Vineeta from IISER, Pune, who is a member of the India Alliance Senior Intermediate Fellowship Committee. Last but not the least, we have Dr. Anurag Agrawal, India Alliance Senior Fellow and Director, CSIR IGIB, who will be moderating this discussion. So the boundaries between basic and clinical research is one of the many gaps that India Alliance hopes to bridge, and we look forward to this very interesting discussion. Over to you, Anurag.
Thank you very much. And sitting here, I can see why everybody is going like this. I did tell them, with the luminaries we have on stage, they could turn down the lights a little, but I guess they didn't listen. With a very, very pleasant duty already being done for me of introducing this very distinguished panel, let me point out the topic we are talking about is exactly what was being talked about yesterday at Vigyan Bhavan. In the next phase of the next 10 years, or maybe the next 100 years, as we heard earlier this day, of the India Alliance, how do we make impact? How do we convert India's strength now in basic research to impactful things at public level? And to do that, one thing that you will realize on the stage, every single person they mentioned has a medical degree. And the barriers, that's the elephant in the room that you can see right here. So if to break barriers for translation, it can't be one direction only. Physicians doing basic, it has to be people with basic research backgrounds doing work of clinical or even public health importance. So I'm going to ask sometimes audience to participate. The structure will be very simple. We will basically talk about 2-3 major themes. What are the barriers? How can individuals accomplish them? And what kind of training would help break the barriers the fastest? And to start with, I would raise one very important point, that our title says clinical research, but there is a very interesting domain within clinical, which is public health. And to treat all clinical research as public health research is possibly a misnomer. And you see again and again examples of people with basic research training getting out to the community. The community doesn't always care about your degree. And with that, I will invite you to take a go and tell us about how you perceive the differences between clinical and basic research, and how do you see the barriers exist in place? And very specifically, do you think the barriers are more to do with how we perceive ourselves than really in science? So Venkat.
Thank you, and thank you for putting me on the spot with a very difficult question. I mean, primarily, when you think about it, I think the divisions that we have created is one of the mindset, and I think that's something to accept. We often talk about a movement from bench to the bedside or bench to the population, but often things happen in the other direction too. This year's Nobel Prize for Immunotherapy to James Allison, the seeds of that idea started with a clinical observation in 1893 by a physician by name Coley, William Coley, who observed that inflammation around a cancer, certain cancers did not grow, so he tried to create inflammation injecting streptococcus, sold it as a Coley's toxin, and that idea was one example of how a clinical observation 100 years later begins to drive bench research. The belt that is used to be what is known to be endemic for malaria was where the sickle cell trait happened. So the connections, the mechanistic connections for both diseases were explored from that. And in the disease that Nikhil and I treat or look after, type 2 diabetes, we now see a lot of thin people developing type 2 diabetes, particularly in countries like India, opening new hypotheses for mechanisms. So I think that's one thing to remember. Yes, basic sciences takes us to the mechanisms, but clinical and population sciences give you the context and also give you a connection. So the idea really is we do science for curiosity, but we also do, and for understanding, but we also do science for impact on people and on populations. And I think as long as those are the anchors that drive science, both the population and the clinical needs, and the curiosity of science and the need for understanding, and connecting it. And I think this is where we need to think of science more as a kind of a pipeline that connects basic sciences, efficacy trials, effectiveness trials, efficiency of delivery, access and availability and distribution. The world of management, for example, Toyota does not just think of the next generation car, they also think of the next generation market. We need to do the same thing with health.
So, I mean, they say you can't translate what you don't know. So basic research, of course, has to precede applications. You have to invest in it. So Gagandeep, the next question, the same line. These barriers between the different type of sciences, the mindsets. You run an institution focused on translation. How do you deal with these barriers? I mean, do you perceive they really exist in terms of these being real things, or do you think there are people who like to be in labs, people who like to be in clinics, and people who like to be in the field, and they just invent a whole thing around themselves?
So I think there is, to some extent, people like to do different things. There are people, I remember a graduate from Vellore once telling me that, you know, what I do has absolutely no application whatsoever and will not have an application in my lifetime. And he was very proud of it. That's Anindya Datta. Okay? Isn't quite the case. So I think people need a draw that brings them to everyone wants to be valued for what they do. How you recognize that value varies for different people. For some people, it is in the context, addressing a question that they view as being important. For others, it is the recognition that comes from what we traditionally recognize in academics, which is publications and how well they do and what prizes they get. But I think the advantage that we have working in a country like India is that the context is actually all around us. So drawing people from different fields to focus on problems that are important to us is probably easier than in many other parts of the world. So I think in Indian institutions in particular, and certainly in the last decade or so, this has been something that people have thought about. And you can see evidence of that in the conversations that scientists from different disciplines are having.
And that's a wonderful point. I mean, inspiration to solve problems are all around us. And no matter whether your background is a PhD or an MD, this mindset is often found. So Ajit, I'm going to skip past you right now and actually go to Vineeta, who has spent a lot of her time as a physician converted, at least in part, to a basic scientist, working in a laboratory, which was mostly basic science. And let's see what you thought were the barriers from that point of view.
Well, barriers were not very apparent because I had never done work with my own hands. And coming to a biology laboratory, I realized that I'm not just looking over a technician's shoulder and trying to interpret things in the lab, as one would call it. And I actually had to do plating. And I thought, oh God, what am I doing? And I have seen this pattern in subsequently when some of the MBBS students came and joined our labs for doing PhD. They were very, I shouldn't say reticent, but it's a strong word, but they were very reluctant to do anything with their own hands in the lab as if that was below dignity. And I think it is also partly the upbringing that we have, but rather than talking about me and my experience, I thought I would probably bring in another point, that we are talking about basic sciences clinicians, and basic science, in my judgment, also includes social scientists. because they are also scientists. Most of us do not think of them as scientists, but they also are scientists. And especially in the public health context, they are a serious part of all the investigating teams. We do get, especially clinicians know this much better, those who are running clinical trials, that there are so-called social workers, and many of them are MSWs and other people who are actually trained as social workers, as social scientists. So if they can do work which is relevant for the public health, why can't so-called natural science trained basic scientists do it? I think they would be able to do it very easily, at times possibly bypassing the clinicians. I had passed on my clinician's mental long time ago, so I can very happily say this, I think.
Ajit, coming to you next. You clearly are a person who has transcended these barriers, the interferon gamma releasing assays, the application to global health and to clinical care. So you're a physician who has run a lab from the basic science point of view as well. And probably, as I was discussing with you, you could have made a living as a basic scientist as well. But you've been part of team building and breaking these barriers. We'll talk about the breaking part later, but what were the key barriers that you saw, first of all, in your own system? And since you've been around the world, what are the barriers that you see in India?
It's a good question, and I'd like to just first really thank Venkat and Cherry for what they said, and the way Venkat highlighted the value, the importance of a single clinical observation from 1893. And he was generous enough to point one out that didn't originate from Emory University. And to say that actually the title of this session is a misnomer, because in her very eloquent answer to the question about failure, Sandhya this morning, she said there's no such thing as failure in science, there's only good science. And so similarly, there's no such thing as basic clinical, sociological, or public health research. There's basically good science, and a scientific attitude and mindset. The microphone keeps going off. Wherever you apply it, if you apply it with the appropriate rigor, you'll get to where you need to go. It's a bit like a boat with an engine. If the boat has a good engine, meaning a good scientific, maybe give me both, and at least one of them.
That's problem solving.
If a boat has a good engine, let's say like good scientific method, it can navigate any situation, whether it's a small river, a canal, or a wide open lake. So similarly, I think it's the scientific method that's important and being rigorous. So with that in mind, I would say there aren't scientific barriers between these disciplines. But what there are, and particularly in India, are administrative, institutional, and with a small c, cultural barriers in terms of how institutions and different professions operate. And there, I would say that to answer your question on the personal level, where you framed it, in my own experience and my own research and clinical trajectory, it was being able to ask the clinical questions of what a new biomarker or diagnostic tool, what that needs to do, what sort of evidence base you need, what is the unmet clinical need that it would be meeting. All of those were the incentives, if you like. Those were the goals, the objectives for me. And without the clinical training, I wouldn't have had those guiding principles. And I think, without going into the details of what I did, which did go from the lab to the clinic to public health, as you said, I think everyone this morning heard the wonderful talk by Ashok Venkatraman, and you could see when he pointed out how he was a clinician trained in CMC Vellore, and you could see throughout his talk that the next step in the research, not always, but very frequently, was guided by the next clinical question, the unmet need, the clinical observations. Sometimes it was driven by pure science, wanting to just understand the mechanism, of the filament, how it's formed and so on, but many times it was clinical questions driving it. So I would say, to cut to the chase, two things. One is that if clinicians can get a chance to do a few years research in a lab, that would be transformative for India. How that's going to happen, I'm not sure yet, because I think the most time-starved population on the planet is the good Indian clinician, because he or she is so much in demand, they just have no time for anything else. So that's one point. And the second is, if there were a better, more intense and regular dialogue between clinicians and basic scientists in India, so that they could each help direct each other's research. You know, I've yet to meet young clinicians in India whose research couldn't be improved by more basic science input, and I've heard many examples of basic scientists whose direction of research, and I'm looking at Sandhya again from her experiences, maybe we'll hear from her later, who's a basic scientist whose research could be better targeted towards unmet need by clinicians.
That is very well stated and sets up Nikhil perfectly. Because you talked about the fact that one of the limiting factors in India is that, you know, you ask yourself, do you know a good clinician who has time? And the usual answer is no. But Nikhil is a very, very well recognized good clinician who, like Ajit, maintains a clinical practice, but unlike the West, does not have the luxury of what we call protected time. So the question I'm going to ask you, Nikhil, before I also try to get the basic perspective on this, is can Indian clinicians doing a clinical job as their primary responsibility run labs?
Okay, I must actually thank Ajit for actually raising two very important issues towards the end of what he spoke. And I think that we are tremendously time-starved because we're not part of a system in the true sense. It's a relative clinical anarchy in which we sort of survive or attempt to survive. And being anarchical as it is, you sort of segue from one activity to the other. In most instances, segue from 4 concurrent activities to another set of 4 concurrent activities. So I'm not really sure if we have an immediate solution for that, but I'll come back to that. But I think more important is the point which he raised about a conversation, right? I've had the good fortune of spending about 3.5 years in a lab, and so which I don't do much with my own hands today, but at least it exposed me to the key issues of and understand what is possible, or at least what was possible when I was more active, and also understand what are the barriers and challenges. Am I expecting too much from a collaborator? Or I'm just saying, oh, this is a problem, go ahead and solve it. It's not going to happen like that. That conversation is very, very critical. So coming back to your specific question, I think it is critical for a clinician to be heavily invested, if not entirely within a lab which they direct, but in a collaborator's lab who is in a regular conversation with the clinician, so that conversation transmits the relevant information from both sides. It's not just doing a bunch of snips for the sake of doing a bunch of snips, right? I mean, you've got to eventually see where that information is going to go and take you. And it's sometimes very, very important for that conversation to take place because the clinical context has to be right. We're talking of biomedical research, and I still remember there was a committee which I'm not part of anymore, which is the usual case, which is called the Chronic Disease Biology Committee at the DBT, and I reminded the audience that it is not a biology committee. It's a chronic disease biology committee. So do not forget that connection between what you do in your labs and what you're trying to address. There's great joy in what Jerry said, that, doing research for the sake of research, generating knowledge for the sake of knowledge, that gives another sense of thrills. But I think we don't have the luxury of doing that, at least not a large part of the times that we spend. So the way we are today, I'm not sure how much time Ajit spends in clinics anymore. Very little. We don't have that option available, right? I mean, I think when institutions hire us, I think that the back of their mind is that you guys will see patients, whatever time you can, carve out of that, you go ahead and do whatever else you can. But your number one responsibility is healthcare delivery. And so it becomes incredibly difficult to micromanage or participate in a lab which is exclusively under your direction, because I don't think you can keep yourself up to date with so many different facets of the same thing. You eventually will have to spend time and understand one particular aspect, and if you're doing respiratory disease, to expect you to understand all the new nuances of managing patients and also looking at the physiology and looking at pathology, I think it's a bit much. But clearly having critical collaboration with which there is a regular conversation to identify issues and address ways of trying to solve them. That for me is the most critical way ahead in our environment today. I'm sorry to sound pessimistic, but I don't see that's the lowest hanging fruit possible, and we're not even doing that.
No, that's fantastic. Not too many people know that you actually have a PhD, and your PhD in diabetes gave you a huge amount of insight, the work that you did. That's something not...
Ajit and I together, he was doing clinical stuff and I was doing...
Exactly, so that's a facet of yours, the 3.5 years of training you talked about, that not enough people realize that he's one of the very few endocrinologists of the country whose primary entry was via research. But let me take one line from what you said. You said in the Indian context, with the doctors being extremely busy, not having the time to ask a question for the joy of asking a question, which is sad by the way, it becomes all the more important for basic scientists to initiate the contact and get things done, if the barriers are to be broken, right? Because I think all of you have said the barriers are primarily in the mind. What Nikhil has said, the barriers are also practical. Some people simply don't have the time to go and ask it. Let's assuming that you break the barriers in the mind, the practical barriers in India will still remain, which means that basic scientists have to initiate much of these breaking. So here I think I'll come to the elephant in the room. How many people sitting in the room right now have a medical degree? And that's a very, very unusually high number for the simple reason we're sitting in the India Alliance program. But even then, the vast majority are people without it. So, Jyotsna, I know it's not fair to pick upon the audience in a panel discussion, but I know you're super sporting and you won't mind. Now you can't. So let me, can we get a mic to Jyotsna? Can we ask you the question from a basic scientist perspective? Because everybody here has access to the medical system. I don't practice anymore, but by virtue of having gone to the same medical school as Nikhil, I have the liberty of approaching him more easily than a basic scientist would. As a basic scientist wanting to make clinical impact, what problems have you faced? And I know that you tried with a CMC Velour in CBS, so really I want to hear the full things from you.
So I won't talk about the CMC Velour NCBS aspect, because that actually is working and that is continuing to work and it's being built upon. And there's a lot of conversations and more than conversations, there's actual collaborative work going on there. I will talk about it more from my perspective as an individual trying to, I work in the area of muscle regeneration. So obviously, since I'm more interested in the basic questions of how stem cells function, etc., it's important to be able to talk to clinicians about not just regenerative or degenerative disease, but also issues of myopathies of many different types. Early in my career, I realized that this was important and I did reach out and started small collaborations. But frankly, it was as much my fault that the collaborations never progressed to the point where we've had an impact. So, I think basic scientists also, you start out, you set up this set of programs, and then you get sidetracked into particular areas which are propelling you forward, and you don't necessarily go back to revisit the issues that you decided were important earlier on. But I am now at the sort of fag end of my career, trying to get back to that by having a lot of discussions with clinicians about different types of muscle disease, etc. So there are very
strong both cultural and practical barriers in this, and it needs very sustained contact and a lot of forgiveness on both sides.
A lot of forgiveness, I like that word. So from, yeah, please go ahead.
Maybe we could perhaps just invite Sandhya to comment, because she's
Yeah, of
awarded
course.
by India Alliance to run
Except I
this
couldn't
new
see Sandhya,
collaboration,
but,
CBA and
oh, right there.
CMC Velour.
See, the lights.
And we were chatting just earlier about the basic scientist-clinician interaction.
Fantastic.
Thank you really very much, Ajit, for asking me to comment on this. And, I could talk about this Margdarshi Fellowship and what we've been trying to do for an hour or more, but I'm going to be very, very brief. There is one thing that I think is critical to continuation of this interaction, and that is that the research that is undertaken by the basic scientist is clinically driven or clinician driven. Now, we all in this audience believe that the science we're doing is the most important science that has to be done. But when you go to the clinician presents you with problems which you would not appreciate. And we've started this interaction with CMC Velour. Again, the CMC Velour is everywhere. It looks like the only medical college in India anyway. But we had to face a lot of challenges. We're based in Bangalore at the Indian Institute of Science, and Velour is at least 3 to 4 hour car journey away. However, when you talk to those clinicians in Velour, you see that they are hungry for knowledge. They have with them problems that they have seen over many, many years of dealing with patients. Now, the research that they're excited about is not necessarily what happens in your laboratory, but it's your job to try to adapt what you do to what they bring to you as a problem. There are 3 things that we're doing as part of this collaboration. Number 1, every year we are inviting clinicians from 2 or 3 departments in CMC Velour to come over to the Indian Institute of Science. And we have a 1-day symposium called the IISC CMC Conclave. Lectures are there given by both institute faculty as well as CMC Velour faculty. And then they break out on the 2nd day to have discussions. And coming out of those discussions are collaborations now between electrical engineers and physiologists in the Department of Physiology. We have collaborations between mechanical engineers and people in cardiology. We have collaborations between gastroenterology and biology. Next year, we're going to do this with neurobiology and hematology, because we see synergy in the way these 2 problems can relate. Because I'm in the institute, we have this tremendous wealth of engineering faculty. We have physicists, we have chemists in our midst. And so therefore, we're able to bring in this interdisciplinary approach to solving medical problems. So that's one thing that we're doing. The second thing that we're starting is, in contrast to what Vineeta said, we are bringing over 12 MBBS students who are in their 2nd and 3rd year in CMC Velour to come and spend 3 weeks in IISc. And they spend their time in individual laboratories, and they just love it. They love messing around with pipettes and experimental work. They have a great time. And they really go back hugely motivated, and perhaps maybe 1 or 2 of them may consider taking up research as a career. And finally, the third most important aspect of this interaction is trying to develop a very strong MD PhD program. Now, Indian Institute of Science cannot give MD degrees, so the MD requirements are done completely in CMC Velour. But in the 2nd and 3rd year of the MD program, those students come over to IISc, start dialoguing with faculty in IISc, and try to develop the research problem, which the MD student brings with them from CMC Velour. And we hope next year that we will have 2 students registering for PhD in IISc. 2 doesn't seem a large number, but it's a beginning. And we certainly hope that this program is really going to be strengthened. And it's been possible only because of the flexible support from the Margdarshi Fellowship. We have to create these meetings, we have to bring students over, take care of them on campus, pay for their stay. All of that's been possible because of the Margdarshi.
That's a fantastic path that we are going, but that brings me to another point. When you create MD PhDs, you're looking at creating transdisciplinary people. So if you want to break these barriers, and this is to the panel again, what do you think is a better way? I mean, to focus energy on building collaborations between people who are experts in different disciplines, or to create transdisciplinary people who are specialized in both disciplines? And clearly the best answer is all of them. But if India has to invest today, and this is more of an India-centric question because we know the MD, PhD programs are already well established abroad, what do you think is the way to go? And Nikhil, I'm going to start again this time from your side.
So let me first go back to the point raised by I think even for that conversation, if you've had an adequate research-based orientation, even that conversation, for a clinician who has had no prior significant research exposure, I think their ability to frame that question and contextualize it to the problem they're facing actually is not as good as somebody who's had adequate exposure. Now, I'm going to give you an admin answer, which is what are the career trajectories for somebody in an MD, PhD in a country like India? Will their absorption into a training of higher medical education institution be easy, seamless, or will they encounter difficulties? And I'm leaving these questions open, but my concern is that that'll be the next set of barriers if they especially want to continue with both. I'm not saying it shouldn't be done. I'm not saying it isn't possible, but I'm just flagging another particular problem. I've always maintained, and I've tried to sell it, but clearly failed miserably, that whether you're doing a basic medical specialty, medical surgical specialty, or a subspecialty, you end up doing at least a 3 years. So look at the US. Look at the US, you're part of that system. You have a 3-year post-primary or basic specialty training, right? Now, different specialties, in that 3-year period, you can actually lop off a year and a half, sometimes even 2 years for specialties like endocrinology to be purely lab-based, right? You don't really need all of that 3-year period to indulge in clinical contact. We've not used that 3-year post-MD-MS suitably, especially for medical subspecialties. I can still understand for surgical subspecialties that you may want to pick up certain skills which you didn't pick up in your basic surgical training. But for medical subspecialties, we have just not done that well enough. And I think for me, again, clearly saying that you can have a 3-year post-MD-MS training out of which people can opt for either a 3-year clinical contact, if that's what you want to do, or an accelerated clinical contact with a protected period of research exposure. Easily doable. Most institutions can do it within. They really don't have to go outside their own institution, take permission from various regulatory bodies, and you will then create a larger pool of people who may be interested in pursuing research. Then, of course, you've got to make, because, you know, that's a formal degree accepted by the medical establishment of the country. So you don't have to then overcome a barrier there. Whereas if you're trying an MD, PhD, which I'm all for, I am an MD, PhD, right? But I encountered, what I encountered, I will not narrate out here because it will dissuade and discourage a lot of people from ever going down that road.
Right. Now, so to summarize your answer, you believe that specialties to talk and the trans people like MD, PhDs to emerge from those conversations, but India is still so far low on the ladder, conversations need to occur first. Venkat, your perspective from the US but for India.
Yeah, I mean, firstly, I want to reiterate a very important point that Ajit made, is that it's the scientific mind that we need to develop, the ability to frame the right question, argue the right framework for it, and apply the methodologies. And those are universal to all science. I mean, I was talking to Mukund, who's a trained physicist moving into biology, and there are anthropologists who have moved into nutrition. So I think, but I also believe that that mindset needs to be inculcated very early. I would even say as early as high school or earlier too. You want to create that mindset of intellectual curiosity and the methods to answer questions. I think that mindset has to be created, not just testing, but the mindset to explore. That, okay. And that also needs to then transmit itself into medical education or into undergraduate education of whatever form. And I think once you do that, you are creating a generation of people who are able to ask questions across disciplines and where convenient, they forge links across disciplines. I think that is very important, that cultural transformation, there's no replacement for that. That has to happen. And I think the places that have done it have gone through that cultural transformation. In terms of what you can do with an MD, PhD, I do believe that a country like India can afford to have MD, PhDs, MD, MPHs, MD law degrees, cross-disciplinary degrees, because I think most of the problems facing health in India are cross-disciplinary problems. And by saying this, I still want to provide space for those who want to remain unidisciplinary and get deep into their methods. We need those people too. But in the larger context, sensitizing the scientific community to understand each other's disciplines, knowing where there is cross-connection, because a lot of creativity occurs in the cross-connections. I think, so I would say, for us, have a broader education that encourages science at all levels, including medical school very early. Like at Emory University, for example, our medical students can take between 4 months to 1 year of discovery time in their 3rd and 4th year. And some of them turn out to be fantastic scientists after that. So processes such as that, and also provide small seed funds to allow such cross-disciplinary pilot investigations to happen. And I think some of it, maybe even if 1 in 10 of them pays off, it pays off big. So I think it's all of this. But you would still have ultimately an elite group that's a MD, PhD group, some who are very basic science oriented, some who are more applied science oriented, but who stay in a conversation. And what kind of institutions you need to promote that conversation is an important one.
I'm going to pick up on one thread from that. That's the importance of introducing the pleasure and joy of science early in school. So Sherry, maybe you can tell us a little bit about the lots of activities as an organization that have been done to inculcate college students, school students into science, while we also get a microphone to Mukund, who can point out what they are doing in Bangalore to promote science. Because the scientific temper has to come first. That's what you said. Only then will the physicians become curious. Only then will the conversations occur. And then the true potential of MD, PhD emerge. The time to change it is before you enter medical school, from what I understood.
Okay, I'm not going to answer your question, but I will speak to what both Nikhil and Venkat have said. You know, what they're talking about is creating an environment and what stage you create that environment at. The ideal is to start really early, to allow our children to ask questions early and learn how to address those questions. Now, given our current school system, that doesn't work. Given our current medical school system, that doesn't work. Given our postgraduate training in medicine, that does not work. So where is it that we are going to start within the system, or are we going to start outside of the system? So what Mukund is doing, some of the things that we've tried to do in Vellore or at THSTI have really been outside of the system. How much can you change outside the system that changes the system itself? That's a really hard ask.
That's a very good point. But we must remember also, I'm the moderator, not a panelist, so I'm going to skip that at Mukund.
Well, I'm not sure what you had wanted me to say, but you put me on the spot. I don't think getting children excited about science is a difficult thing. I think it comes quite naturally. School system might beat it out of them, but I think that's a fairly easy thing to deal with. And we've even heard about outreach that the Alliance is catalyzing. All of us can do it at a small and local level. In fact, I think the problem is on the other side. It's about personal growth and fulfillment when you're working as a scientist. And when you're a basic scientist, all the reward structures are totally artificial. Now, I'm speaking, the grass is always greener, but when you're actually working on something that makes a difference on the ground, then those are real mechanisms of fulfillment that keep you going from day to day, even when everything is going bad. When it comes to the point of how to get people to think creatively and collaborate, I think it's very hard. I think collaborations are extremely rare. You can maybe set up the opportunities for collaborations, but you have to set up expectations to know that it's probably going to fail. And these repeated collisions that lead to collaborations, how do you set up a system? If you can solve that problem, then you've really hit the jackpot.
So Ajit, on that note, and so I completely agree with you, Shri, by the way, that there are structural problems, and most things we have to do will come from outside the system. The examples you are giving are from India Alliance, which is not within the mainstream system of the country. So is everything that you're doing. But given the very small pool of people we have at that interface, everything is a good thing. So Ajit, coming back to you, I mean, these challenges of difficult collaborations, people colliding, enthusing people, I'm sure are relevant even in the UK. So I mean, how do you deal with it?
I mean, I think in terms of what could be done here to improve the situation, I thought Venkat outlined very nicely areas for future investment. And rather than speak myself, what I'd rather do, with your permission, is there's a fellow, a cardiologist, who our committee funded a few years back now, working in Bombay, and speaking to her just earlier, Banu Dugal. She's had a couple of experiences which I think would be enlightening for us. Just very
I agree
briefly,
completely.
Banu, if you could just very briefly summarize what we discussed over lunch and your experiences of the obstacles you faced.
So basically, my grant was on intravascular ultrasound. It had a clinical part and it had a basic science part. We were going to find miRNA biomarkers which correlate with the atherosclerotic plaque. So doing the clinical part was easy for me. I could do the imaging part, though there are always certain obstructions from the higher-ups here, because I needed extra cath lab time, which initially my boss wouldn't agree. I needed 1 hour to do a cardiac cath, which I could finish in 5 minutes. So that was the initial hitch in starting the clinical part. The basic science part I learned in the US. My mentor was from Cleveland Clinic, Dr. Prasad. He guided me. I worked in his lab for 6 months, trained myself in all the basic science parts. But the problem is getting the atmosphere here. Like, okay, Dr. Tandon Nikhil Tandon is in AIIMS. I'm also a product of AIIMS, so probably that has kept us alive, the spirit of inquiry alive in us. So and Anurag is also from the same institute. So it's probably the bringing up that has kept the fire alive. But it is very difficult to find collaborations over here. So I had learned everything, but setting up my own lab, because there was no lab in Grant Medical College which would do that kind of work. I spoke to people in TIFR and they were not coming forth. They said, you cannot bring human samples over here. I went to IIT Bombay initially to find a lab which could do the samples and I could work immediately. But they were not willing because they were more interested in cancer research. So the 2 or 3. So I had to set up the lab, which took a lot of time, around 1.5 years. So these are the problems we as clinicians are facing. I mean, everyone does not have that CMC and they have built a collaboration, but that is the problem we are facing.
I'm so glad you said that, because no matter what we say, ultimately we represent only a few elite institutions. Very important thing that Bhanu said, and I think for the audience, the clinicians think they have a hard time finding collaborator, and based on the large number of basic researchers I speak to, they keep pointing out it's very hard to find a clinical collaborator. I think the reality is, in both fields, the number of people who want to do collaborative high quality research is very small, and it's difficult for them to find each other by simple diffusion. So on that, can I ask Vineeta to say, how do you think the ecosystem can allow these people to find each other? Without a matrimonial ad.
I haven't given one out, ever.
Touche.
Can I go back
Yeah,
to
yeah.
some of the earlier and then come back
Sure.
to here? We were talking about elite medical colleges. I went to a state medical college called BJ Medical College in Pune, and you are going to hear somebody who also belongs to that college in the next 2 hours or something. That's Dr. Mohan Agashi. I can't see him in this slide, but he's here somewhere. Thank you. But all I'm saying is that we have been talking about CMC, AIIMS. Of course, these are great institutions, but people who come from small institutions also on their own can have drive, and if they don't have drive, instilling that drive is much harder because of what Cherry said earlier, that you can't go out of the routine that is set up. There are very many limitations, and that is a problem which is a large-scale problem. We talk about AIIMS and CMC and a few other institutions because we can count them on the fingers of one hand. The rest of us are ordinary medical graduates. So unlike in the elite institute, so it is an important point that we don't want the culture restricted of medical research or clinical research only to elite medical institutions, but also it has to be spread all over. And I think that also we need to look at, and that's why restriction about the time you have and everything is important. The second point which I wanted to talk about earlier, and I think because there are also non-medical people here, it's important that everybody is talking about MD, PhD. In the US, MD is our MBBS. So we should actually be talking about MBBS, PhD, and that is earlier than MD, PhD. So you can imagine that MBBS is 4.5 years plus 1 year, or whatever, 5 odd years. MD also is 3 years, and after that, if anybody wants anybody to do PhD, the time, of course, time you spend in getting something, a degree itself, is a problem. And that's one reason why I think in India, MD PhDs are very hard to come by, and MD PhD is in that sense an impractical option. And I keep thinking that what you said, 6 weeks to 10 months or whatever period that you can take off, that should actually be introduced during MBBS. Because non-elite medical colleges, at least I know, that they do not talk about requirement of science or research for progression of medical devices or medical treatment and everything of that kind. So research is not discussed, at least in colleges like BJ Medical College in Pune. I'm not calling it a bad college because I think I got very good medical training in it. But there is still this aspect which is certainly lacking, and I think we need to think about how to introduce or expose MBBS students who are doing MBBS to various degrees. The science academies had tried to do something of this kind, but it was a miserable failure because somebody wanted to come to me, but they always have internship to do or this or that to do, and hence they cannot spend time in clinic, in the basic science lab, which is again going back to what you were saying. The third part actually I wanted to make a point is that yes, I dislike many things that the present government says and does. But if we want to talk about nationalism, which is what they are pushing for, that can be one of those, what should I say, driving forces for many youngsters so that they want to do something for the country. This is not the nationalism that is expected by the present government, but I'm giving it a twist. But it can be a driving force, and that would be something that people would like to pursue. And I think that we should try and exploit, because if nationalism is being pushed, maybe even this kind of getting something done on the ground by the medical students along with IIT and other bioengineering kind of students is a great idea. And that is where, again, in the early formative years, possibly people across the discipline can come together.
Missions bigger than the individuals that people join.
Yes, and it has to be a collaborative effort. It cannot be a single effort.
I'll just put a plug-in for India Alliance, another activity. Shinjini knows it well. Developing Indian physician scientists, something the Alliance supports twice a year. 67 physicians have had a chance to come to research institutions and then be exposed at least for 4 days to see what all is happening. And I'm going to open it up to the audience, unless anybody wants to add something. Shari, then we go to the audience.
So I know I was very negative about the system, but I think going back to what we said earlier, one thing people have to remember is that in medicine in India, at the postgraduate level, we have a requirement for people to do a thesis, which means we have built into the system the opportunity for research. Mostly what happens is not even incremental questions, right? Most often it is, how do I get this out of the way, because it is a requirement of the system. It's not really about learning to ask good questions. I think where we need to think about institution rebuilding is to create opportunities to ask better questions. That comes with broader relationships than people just within your field. One of the reasons that you hear about CMC is because at least some departments in CMC, hematology, gastroenterology, the neurosciences have always been departments that have had faculty who were not just clinical. So you had physiologists, pathologists, biochemists, etc., interested in a particular area. So you could move the clinical science forward, but you could also think about answering questions about mechanism. Now, I don't know whether that happened equally in AIIMS, but how do you multiply the number of institutions that do that? And how do you now start thinking about links beyond these elite institutions? Because now we've got science institutions in many more places than we had before. So it's time to think about those links.
Again, two very potentially amenable and simple things in the short run. We have identified two issues here. Number one, the elite institutions, and for that wealth to spread to, or the quality to spread to, lesser institutions. And then about how you seed interdisciplinary research. One potential way might be to create networks of institutions which come from these two axes. And then you incentivize collaboration. So ultimately, if you pour some honey, bees are going to fly into it. I mean, that's the way things happen. So if you did that, suppose you created a network of 10 institutions, which is a mixture of basic science, public health sciences, mixture of elite and less elite, and then you promote that collaboration through some methods, then over time, because essentially that will provide an institutional framework for great collaborations to happen.
Nikhil, you want to say something?
Yep, so let me just make brief comments on 2 or 3 points that you raised. One, this distinction between a type of institution and another type of institution. I think the important thing to understand is what has been really the culture in that institution, what has been the emphasis of the faculty. This business about MD dissertations, we've heard repeatedly, and it's an opportunity lost. There is no question about it. But the issue is, whose responsibility was it to end up with a half-decent MD dissertation, right? To expect the postgraduate to drive that, this is somebody who's not had any prior exposure. It usually is very poor mentorship, right? Let me say it another time. And it's, importantly, it really depends on what has been the ethos of that particular institution. Sometimes even within institutions, there will be significant heterogeneity. Cherry raises the issue of 2 or 3 departments having a slightly different approach because of the nature of the faculty within that. So the first issue is to see whether you can bring about a cultural change to say that this is something important. Now, unfortunately, in today's day and age, what is important, you need to show an immediate, tangible, translatable value of what you're doing. If 99%, and I'm going to make a statement which makes me, I don't think there's anybody who's got a cardiologist, say some Bhanu will kill me. 99% of the cardiologists actually just want to go out and do cardiac caths, right? I don't see a cardiologist who wants to actually enter into research. So, because they see that's a more attractive career option down the line. You can't expect things like this to grow in isolation. It is a whole chain which is critical. Not merely that you provide an environment and you expect people to do something, but also see where that is going to lead. Ajit took an option of being a clinician scientist. I'm sure there were classmates of his at Oxford who decided at that point in time that they'll be general practitioners or DGHS consultants. Right? They had the same opportunity, they had the same mentoring. So it also depends on what your personal preferences are, but also really depends on what are the downstream career opportunities. And that is very critical in our environment to see that what is the advantage for me? And that question which is asked is, what is it in for me in this?
So to rephrase, only a small fraction of the medical community, being primarily professionals, are interested in breaking these barriers. A larger fraction of the research community wants to break the barriers. And as you said, creating missions is one way of getting there. As you said, creating networks is one way of getting there. And of course, if small number of people might get there sheerly because they're interested. But now let's quickly, before we end, get some audience questions in place. Yeah, I'll let the boss do the handing around of the mics, because I can't see you from here. I can see you, Ashok.
Sorry, was it me or someone
No,
else?
that's fine. I can see you. Yeah, go ahead.
I had an observation to make concerning a lot of the very interesting discussion that's gone on. And that is at the heart, in my opinion, of breaking down barriers between basic and clinical science. In fact, in just doing good research, whatever your sphere of activity may be, is learning how to ask a question. And it seems to me that you can get trained in all the methods in the world, write all the dissertations in the world, but if you don't know how to effectively ask a question, it's very difficult to do good basic or translational science. And the second observation that comes as a corollary of that is how you ask a question concerning a particular problem. And a perhaps grossly oversimplified way of illustrating this is the following example. We all know that most people who have cancer die from metastasis. So how does one address this issue as a burning problem? But whereas a basic scientist may ask, how do cells move? A clinician might be prompted to ask, how does cell movement contribute to metastasis? But fundamentally, these are different flavors, if you will, of a very similar problem. And when people come to a recognition of these underlying similarities, that's when effective collaborations flourish. So really, I just wanted to emphasize how important it is to learn how to ask the right question.
I think that cannot be emphasized enough.
We have a question there.
Yeah. Yeah, yes.
When it comes to breaking the barriers again, we have to understand, as Vineeta mentioned, health is not a concurrent list. It's on a state list. So the economics is very important, what goes where. And so even if the decisions are made by the health and family welfare here, they are not necessarily implemented in the states. And this becomes a major obstacle. I'm the Directorate of Medical Education and Research for years together did not even have a penny reserved for research. So there are some basic factors for a country like this which really have to be looked into at all levels. And the second is only interest and ability. During training itself, undergraduate, you can identify who have basic inclinations and abilities for research and those who are good teachers. So imposing research on every teacher is not necessarily biologically and psychologically good.
We have one question.
Would anybody want to respond to that? That's a good point.
There's something I would like to add. I'll just introduce myself. I am an MD from Lady Hardinge. I don't know how elite a medical college is that. What I feel is that the paraclinical branches we have, like the 4, anatomy, physiology, then we have pharmacology, pathology. There's a lot of time the postgraduates have in these branches. So that is something we can always exploit, because these branches do not have emergency duties or 24 hours duties. So they have a lot of time, and they are basically trained in research. So because I did my MD in pharmacology, but there's certain things that medical colleges lack. Like we did not have pipettes or something as basic as a centrifuge. So even in Lady Hardinge, we did not have a centrifuge. The biochemical lab will have for the diagnostic purpose, but for research, we don't have basic equipments. So one thing that the funds are lacking. 2, even though they have a lot of time, the biochemists, physiologists, anatomists, but they do not have the right opportunities. Even community medicine people, they want to do a lot of things, they just don't know. I was lucky enough to get associated with Dr. Anurag. So I will go ahead and do a PhD, but I don't think so many of my colleagues get the same exposure. So when they hear from me, they are very excited. Another thing which again we discussed in this panel discussion is clinicians have a lack of time, which is very true. But again, they want to collaborate. So they don't know how they can help. Many of my friends, what they say is, like I have a friend who's a neurosurgeon. He'll say, I have a lot of samples, a lot of questions, just do the work for me. So I can give you everything, just do the work for me and give my name in the publication. So actually that is what they care about, but I think that's a great opportunity. So I don't know, but the paraclinical branches can be probably roped in.
So we'll take only one more question by Satyajit Mayer after this, but perhaps you can answer this.
Maybe I can respond to that, and I will bring it back to, it's not really, if you look at Nikhil, he does not have time, but he still does stuff that addresses what are truly important questions in diabetes today. So going back to what Ashok said and what I said earlier, incremental anybody can do, and it is almost required of us. The ambition comes from asking bigger, better questions. And that's where you need the conversations across fields. So I'm glad you found Anurag. Send more of your friends this way.
We'll take the last question from Satyajit.
No, it's actually not a question, but a small
comment is welcome.
It's a small comment. It's also about how one builds up the interaction with the clinical ecosystem in a city. So, for example, in Bangalore, we've between the NCBS and INSTEM built I think quite an extraordinary collaboration with folks at NIMHANS to build, perhaps for the first time, a very large repository of deep clinically phenotyped neuropsychiatric disorder cohorts, from whom not only the biology but also the clinical implications of this cohort are happening as we speak. But what I wanted to speak to was the effort it took to put this collaboration in place. It's taken, I think, 20 years of conversation with NIMHANS, people that we've known as colleagues, friends, engaging over 20 years to understand how we can collaborate and put together what I think today will be an incredible resource for the whole world. Simply because NIMHANS has been tracking patients that have multiply affected individuals and families, and over 500 families now have signed up to be part of this study. But this doesn't happen overnight, right? It happens by the clinician also believing that what the basic scientist is doing has quality and can bring value to what questions they have. But now that this resource has been built, it should open up the possibilities for many more basic scientists and many others from the clinical community to engage in asking questions around this resource, not only because it's perhaps unique, but it's also been locally generated. Right? So I think, what you're saying is the conversation is, I think, very important, but, at some point one has to give it time to evolve and also have the right elements of trust that develop alongside the institutions. And 20 years is not a long time, but it's going to take us 20 more years to even begin to address the kind of resources that have been built.
So Deepak will not let you have the last word. So Deepak.
Thanks, Anurag. As it's a great discussion, and as we are discussing breaking the barriers, basically empowering physicians to break the barriers and get into basic research, I have a flip side to this, and it is through a program that I am a part of, and that is if medical institutions could encourage young students to take up medically relevant problems. And I am a product of AIIMS. I do not have an MBBS degree, but I have a degree which is, unfortunately the program is closed, but it was a Bachelor's of Science honors program in human biology. that AIIMS started off in 1980, and my good friend Rashna Bhandari here is a product of that, and we both, and I mean, so it was a great program where, as Professor Gagandeep was just mentioning, I mean, some of the great departments of the medical colleges have very strong biochemists, physiologists. After all, medicine is also a science. And there are a lot of basic, problems that one has to address within that, which are of great importance. And I think the pool of scientists produced through this has really taken up to these, taking up these big questions in medicine. So I think, unfortunately, the program is closed, but I do feel that there is a lot of relevance in, bringing about, encouraging basic students to take up medicine, medically relevant research careers, because just as some of the points mentioned, that probably physicians are too, tied up and don't really have the time always to attend to some of this. So this is just a point. But
I think Deepak's point of the human biology program in a medical college would resonate with everybody on this dais. And of course, during Nikhil's tenure, it shut down. So let Nikhil answer that.
So I'm the chap who shut it down. Okay. No. So Deepak, I totally agree with what you're saying. It was a great program. Started a year ahead of when I was a medical student, and the tragedy which led to it shutting down was not because we had any doubts about the course, but the fact that in this country, when people in biology went for a master's admission, in 9 out of 10 universities, they were told, well, we don't recognize a BSc. You're not a BSc in biology or botany or zoology or biochemistry. We don't know what garbage this is. You can't do a master's.
Okay,
So
we
I
heard
will
a not
actually
true voice
was
from
the
the
sub-dean
periphery,
and I shut
but
it
we'll
down.
take that offline. Let me just now quickly summarize, because I think we're really at the end of our time. It seems from everybody in the dais that India has a tremendous opportunity to do highly medically relevant research. Problems are around us. It seems from what every one of you said, most of the barriers are in the mind. It is and financial opportunity, of course, and so on. But dialogue seems to be critical to get both fields together. And down the line, if we pursue this long enough, as Satyajit said, we will get true transdisciplinary people like MD, PhDs, and so on. With that, I think we'll conclude this panel discussion. And thank you all very much.